Good morning, and can I welcome members, invited guests, officers and the public to this meeting of the Health Committee. Now, I'd like to start today by taking a minute's silence to express our sadness at the tragic death of Sir David Amess, MP, on Friday. Thank you, everyone. Now, today's meeting is to gather evidence for the committee's investigation into reducing drug deaths in London. We encourage anyone taking part in the discussion on social media to use the hashtag #AssemblyHealth. We have a few short items of formal business to go through first. So can I ask our clerk, Diane Richards, to confirm any apologies for today's meeting?
Thank you, Chair. Apologies for absence have been received from Assembly Member Dr. Sahota. Assembly Member Desai will be substituting today.
Thank you, Assembly Member Desai, and welcome to the meeting.
Thank you, Chair. And can I give my apologies? I will have to leave the meeting around 11 in connection with other GLA business.
Yeah, absolutely understood, and thank you very much for making the time to join us. So can I ask members to note the list of offices set out at item 2 of the agenda, and also ask if members have any other interests to declare? Assembly Member Boff.
It's not a pecuniary interest, but I am a member of the Conservative Drugs Policy Reform Group, and because that's so directly relevant to this discussion, I thought it was fair to state that. Though it's not pecuniary, I don't earn any money out of it.
Thank you very much. Can I ask the committee to confirm the minutes of the meeting held on the 14th of September 2021 to be signed by me as a correct record? Agreed? Agreed. Lovely. And can I ask members to note the outstanding actions arising from the previous meetings of the committee?
Noted.
Thank you. So that brings us to our main item on today's agenda, and I'd like to welcome, we have 3 guests in the chamber and 1 guest joining us remotely. So first of all, welcome to Neve Eastwood, who is the Executive Director of Release, to Steve Rolls, who is the Senior Policy Analyst at Transform, and Dr. Prun Bijral, who is the Medical Director of Change Grow Live. And joining us remotely, we have Professor Alex Stevens, who is Professor in Criminal Justice and Director of Public Engagement at the Faculty of Social Sciences at the University of Kent. So welcome to everyone. And I'd like to begin by asking each of our guests to introduce themselves briefly, stating who you are, the organisation you work for, and what you specialise in. But if we can keep it brief, that would be completely fantastic. And I'm going to come to Alex Stevens first to bring him into the meeting, who is going to join us remotely. So Alex, over to you for who you are, what your organisation is, and what you specialise in.
Very much, Chair, and thanks for the invitation to give evidence. My name is Alex Stevens. I'm Professor in Criminal Justice at the University of Kent. I specialise in researching the overlap between drugs, crime and public health, and it's also relevant that I was the lead author of the Advisory Council on the Misuse of Drugs report on reducing opioid-related deaths, which was published in 2016.
Thank you very much. And could I come to Prun next?
Thank you very much. So my name is Dr. Prun Bidral. I'm a consultant addiction psychiatrist and medical director for Change, Grow, Live. I, up until last year, served on the technical committee for the Advisory Council on Misuse of Drugs, and I currently sit on the executive of the addiction faculty for the Royal College of Psychiatrists.
Thank you very much. And Neve?
My name's Neve Eastwood. I'm Executive Director of Release. Release is the UK's Centre of Expertise on Drugs and Drug Laws. We provide services to people who use drugs, particularly people who are drug dependent, addressing their legal issues. We also undertake research into alternative models for dealing with drugs, such as decriminalisation, highlighting the harms of current drug policies and drug policing, especially in the area of racial disparities, which is relevant to the situation in London. Thanks.
And Steve?
Yes, thanks. My name's Steve Rolls, and I'm the Senior Policy Analyst for the Transform Drug Policy Foundation, which is a UK-based policy and advocacy organisation working in the field of drug policy and law reform. I'm actually here today with a kind of hat on for an organisation called The Loop. I'm sort of standing in for Professor Fiona Measham, who unfortunately can't be here today. She is the director of The Loop. The Loop's a non-profit harm reduction organisation founded in 2013 with a mission to provide high-quality, evidence-based and evidence-making drug checking, advice and information, training and in-house research and evaluation. So I'm here with two hats on, but today I will mostly be speaking on behalf of The Loop.
Thank you very much to all four of you. So my first question, which again is something for all of you, is can you each outline a factor behind the increase in drug-related deaths in the last few years? Neve, maybe I'll start with you.
One factor is...
One factor. I'm just giving you one factor each. So
okay, I'm hoping that my colleagues will pick up on lots of the other factors. I don't think we can ignore the fact that we've seen a significant increase in drug-related deaths since 2010 and the introduction of austerity. The decimation to treatment budgets, the decimation to the social welfare system has had a profound effect on folks. And you know, we've seen an increase in drug-related deaths in the UK year on year since 2012. So for me, austerity is a major driver of that. Inequality is a major driver. And we do need to be looking at solutions that are based in investment in our communities. More broadly, though, and this is, again, I presume will be picked up by my colleagues, is looking at interventions that we can support to get people into facilities that can reduce the risk of death, and in providing interventions that can reduce the risk of death. And I know we're going to talk about a lot of those today. So I think investment in communities, but also specific actions that can reduce the risk of drug-related deaths in some of the most vulnerable populations. And it's really important to recognise these deaths mainly happen in populations that are socio and economically disadvantaged. So it's really about addressing the experience of people who live in poverty.
Thank you very much. Alex, I'm going to bring you in remotely. So would you like to just outline just one factor behind the increase in drug-related deaths over the last 10 years?
In the ACMD report that I mentioned, that was published in 2016, we highlighted 4 factors. One being the increase in availability and purity of heroin since 2012. Another being the ageing of the cohort of people who started using heroin in the 80s and 90s. A third was austerity, as has been mentioned by Neve. So the lack of availability of the services that people use drugs rely on to achieve recovery. And fourth, the cuts to drug treatment services that Neve has also mentioned and highlighted by Dame Carol Black in her recent report on drugs. But the one I'd like to focus on is the failure of government and other authorities to respond to the increase in drug-related deaths that was visible to us in the mid-2010s. And the ACMD made several recommendations in its report in 2016. Those recommendations were officially accepted by the government but have not been acted on. The main one was to increase investment, or at least maintain investment in opioid substitution therapy of optimal dosage and duration. Since that recommendation was made, which the government accepted in word, funding has continued to be cut for those services.
Thank you. So more on the serious impact of lack of funding. Prun.
Thank you very much. Yeah, I agree with everything my colleagues have said so far. It's very difficult to pick one factor because it is multifactorial, of course. However, from my perspective as a clinician, I think quality treatment has to come up there as a main thing, and people that are suffering, people that have problems with drugs, who are suffering with those the drugs when they cause significant problems, having the ability to access care as a health condition versus a criminal justice issue is significant for me. So barriers to treatment, wherever they might be, either at the policy level, system level, the stigma around drug use, these are all barriers to actually engaging with evidence-based treatment, which has been shown to reduce drug-related deaths, improve well-being, improve physical and mental health, and improve a wide range of factors. So from my perspective, I think the significant cuts in treatment over the last decade have meant that we've not been able to keep pace with the demand and the wider challenges that exist as have been described. So for me, that's a big issue that needs resolving.
Thank you. And finally, Steve, is there anything that hasn't been mentioned yet?
No, I mean, I obviously endorse and agree everything that my colleagues have said. I think this wider political context in which the drug debate plays out, where there has historically been an emphasis on criminal justice interventions and the inevitable criminalisation of people who use drugs. And that burden of criminality that this significant population, which numbers millions of people, even within London, does create, as Prune has alluded to, it creates barriers to effective public health interventions. It fuels stigma around people who use drugs. It diverts resources away from proven public health interventions into often unevidenced criminal justice interventions. And it just creates a public debate and political discourse which is often focused more on populist tough-on-drugs narratives than evidence-based public health thinking. And we really do need to have a fairly significant reorientation of policy away from some of these failed ideological war on drugs, posturing of the past, towards evidence-based public health interventions that have been shown to work here and elsewhere around the world.
Thank you. Thank you very much. Krupesh, did you want to come in?
Just very briefly, because I think some of the points, part of my follow-up was about austerity, but I just want to sort of turn that angle around, because obviously from this chamber we won't be able to change the government's policy on it, but just reading through Dame Carol Black's review, which suggested that for every £1 spent on treatment services, it saves the state £4 in interventions from prison service, from health services, from law enforcement and emergency services as well. So taking that sort of argument around and looking at how the government views finances at the moment and has done over the last 10 years, what work do you think that we can do from the Assembly to highlight some of those issues and the financial case, really, that it's not that these services cost the state money, they save the state money?
I'd be happy to start to answer that. It's very well understood. You're right to point it out that actually spending money on treatment does save money. for the wider system, for sure. So that evidence is well established. So just to support the evidence, and going back to what Steve said, all I think that we might be talking about is follow what the evidence says. But then there's also, I would say, for this treatment is cost effective, certainly, but it also saves lives. And the cost to individuals, the cost to their families is not often considered, and should be here in the room today with us, I think, when we're thinking about money spent in efficiency as well.
And just to add, Prune has mentioned about the treatment quality, and one of the things that is really important around treatment is to make sure that we're creating an environment where people feel that they can access treatment. And in the last 10 years, we saw a real focus on the recovery agenda as defined by abstinence as the goal of treatment. And that may sound like a wonderful motivating approach, but the reality is for a vast majority of people that will turn them off treatment. So I think one of the things at a city level that can be done is embracing the principles and philosophy of harm reduction. So really looking at those public health interventions that have been evidenced, which we will talk about in more detail, but that are the gateway into accessing support services, not just treatment services, but also housing services and broader social interventions, and how that can save money in the longer term, but also, as Prina said, save lives.
I've got Alex wanting to come in remotely, Krupesh.
Thank you. It's true to say that the London Assembly doesn't have much power over the overall policy of austerity, but we have seen success in the past where resources at local level have been pooled between public health and criminal justice actors so that they can spend on those aspects of drug policy which are most effective, which are harm reduction and treatment. So the pooling of budgets at local level has been shown in the 2000s, but also more recently, for example, in Essex, to be an effective way of trying to combat some of the deleterious effects of austerity.
Thank you. Are you?
Something's just come out of that I just wanted to...
Pick that up.
Do you feel you have the support of colleagues maybe who work on the end of the spectrum dealing with acute care? Just bearing in mind, we've spoken about the savings that could be developed, or even interventions that really don't need to happen because they haven't been dealt with earlier on in the system. And do you work in particular with any organisations or parts of the health system to try and maybe get them to invest in prevention services as well?
I'd be happy to take that. I'll use an example to perhaps illustrate your point. If we think about chronic health conditions that affect people, that do cost a lot of money, that are a significant burden on communities, people's lives, primary health care services, and then ultimately secondary care, like hospital settings. If we think about respiratory conditions, chronic obstructive pulmonary disease, that often affects people who use drugs, but they are so rarely the ones that actually get access to treatment because of a number of factors, including access to primary care, being registered with a GP, all of the things that we might take for granted that you need to have in place before you can then actually go and access that specialist care. Sometimes it's too late. The problems have actually already developed before then. But with the right investment and connecting up as systems, which is what we have to do, actually, and Dame Carol Black, you raised it, that's what the vision is, I think. Hopefully we should be able to start getting the services to the people where they're required, rather than expecting everybody to actually get to services which might not be as realistic.
Just there's a really great real-life example of that in terms of the research that's been undertaken by Magdalena Harris at the London School of Hygiene and Tropical Medicine around wound care. So she went out into London and interviewed 455 largely public injecting users, people who had to publicly inject because they're homeless, because they have unstable accommodation, or their accommodation could be lost if they injected in it. 65% of them reported a soft skin tissue infection, so bacterial infections that could ultimately lead to things like amputation, which is really, awful for the individual. The fact that this is happening in the 21st century in London is quite shocking, but the cost to the health system is huge. And the 65% who reported having these problems delayed accessing treatment, largely because of things like judgment within secondary care settings. So there's an education piece, I think, to bring colleagues along on the experiences of people who are drug dependent. Also to fear of not being able to access opiate substitute therapy. So methadone, if they're prescribed methadone, often there are problems within hospital settings about getting timely access to their medication. Often these folks are seen as drug seeking, so the prejudice and judgment that they face again in those settings means that there's a delay in accessing their medication. So there's this whole piece that could be done within London, and we're working with the school on a large research piece to work with specific hospitals across the country. But I think, again, this is something that the Assembly could look to do, and the education piece, I think, across, as Prina said, primary and secondary care.
Thank you. What about, because we haven't yet mentioned COVID, and this last 18 months has changed everything for everyone, and I just wonder how COVID has impacted the delivery of harm reduction interventions, and particularly those that are targeted at preventing drug-related deaths. So I was going to direct that to Niamh and to Prun.
Go first as a service provider.
Yeah, it's like everything. It's had a massive impact, and it had a very, very rapid impact. Again, I think like all services were affected probably at the time. Some services stopped. Absolutely. For example, hepatitis C testing. This is something that we're really trying as a country, as a world, actually, trying to get to elimination of a different kind of virus. And then as soon as COVID came in, we had to stop that. So we talked about populations that couldn't normally access healthcare or couldn't normally access treatment that they're entitled to as citizens. Hepatitis C testing and treatment is one of those, and that effectively stopped at the beginning of the pandemic and then all the way through. Things like needle exchange, accessing those very essential sterile equipment for people who needed them, also got severely impacted because a lot of those settings might be in community pharmacies, for example. We know that community pharmacies were massively affected, in terms of staffing, capacity, just trying to meet the needs of the communities that they served. So you can imagine that if it was hard enough for people to access those services, with all their wits around them, with all their capability and all the support they might have, and then you might have some of the most vulnerable members of our community then trying to access those services, they were always going to struggle. As a treatment provider, that's my day job, is medical director of a treatment provider. We had to adapt very, very rapidly, and we had to make quite significant changes to delivery of core interventions like provision of methadone. That included improving access and flexibility for people who were struggling to get out and about in the community, obviously because of the restrictions that were there. So we did have to adjust things. I think it's fair to say that was a tough time, but on balance, what we were able to see is that by keeping the person at the center of what we were trying to do always, as a sector, I think we largely managed to help people stay in treatment. It's not that, at any point in time, we've got about 40% of the people who need treatment in this country, I think that's probably right, isn't it, Niamh, who are not accessing treatment. That's a lot of people. And so it's not easy to get into treatment, it's not easy to stay in treatment. And what we're trying to do, and what we're trying to do pre-COVID, and especially during COVID, is make treatment very easy to get into, very easy to stay in. And thankfully, we did manage to, as a sector, I believe, maintain that treatment population, actually increase numbers of people into treatment because of some of the changes I believe we did as a sector to reduce the barriers down. But it has been a significant challenge for treatment providers, but not more so than those experienced by people who need to use frontline services.
Niamh.
Yeah, just to echo really what Pruna said about access to methadone prescribing. I mean, what we had prior to COVID was largely a very high intensive system for the majority of folks who are in drug treatment. So probably about 50+% on daily pickup, is that fair? So having to go every day to the chemist to pick up their medication, many of them supervised, so having to take their medication at the pharmacist. And I would say that that's largely due to there are some real concerns, but it's largely due to stigma around this medication, that the people who are accessing it aren't seen as trustworthy, that they will divert their medication. So this is not about serving their health needs, it's about concerns that the medication will get out into the wider black market. And so it's really important that when we talk about this population, we recognise the harms that that kind of system can cause, because 60% of people who are dying across this country at the moment of drug-related deaths aren't in treatment and haven't been in treatment for the last 5 years. And we have to ask ourselves, why is that? And I think the changes that we saw in COVID, and it was Herculean what the drug treatment providers did in this situation, it can only be welcomed. But what we saw was a shift to a more open access, to trusting people with their medication, to giving them 7-day scripts, 14-day scripts, to making them feel that they had dignity in their treatment. And I think we saw across a number of areas, including in London, a significant uptake in treatment access and people accessing treatment because of those changes. There were other factors as well, as such as concerns about being able to access the illicit market because of shutdowns across the world. But largely people found that system much more beneficial. And just one sort of anecdotal story from that. I was speaking to a client of ours that we support through our advocacy helpline, and what she said to me was having to go every day to the chemist became, I mean, apart from the fact that it impacted on her ability to get her kids to school in time and all of those various things, but also too, it meant that her day was regimented around that going to the chemist. She left the chemist. She would then be approached by someone who is supplying illicit heroin. So in fact, the shift to her getting a larger quantity of her medication over a 7-day period meant she wasn't having those daily journeys, meant she wasn't meeting with the person who was supplying illicit heroin. And so it broke that chain, and she felt much more in control of her own treatment plan and much more trusted by the treatment service. So I think that's a real positive. As I said, we should be applauding the treatment providers for what they did in this situation, and learning from it moving forward and not losing those really valuable lessons.
You were saying that that some people are the reason that it wasn't normally happening with the distribution daily from the pharmacy was that people were concerned about methadone ending up on the black market. Did that transpire during COVID, or was it, were those fears did those fears not materialise?
I mean, certainly. So at release, what we did in March, April last year was set up a national surveillance network of people who use drugs, people working in harm reduction, those who were on the ground who could tell us what was going on. And I have to say, largely we heard of very little diversion, certainly almost no diversion in the first kind of 3 to 6 months. Now, as things have opened up, we are hearing a small amount. But again, I think we have to look at the balance of risk here. If we're getting more people into treatment who are at risk of overdose and death, that's a good thing. If there is a small increase in diversion into the illicit market, that's not great, but that's going to happen because there is more medication out there. So I think this is about balance of risk, and at the core what we need to be doing is pursuing policies that protect lives and save lives, and this does that.
Thank you.
Yeah.
So my next question, London has particularly high levels of recreational drug consumption. Do you feel there's sufficient attention targeted at this form of drug use? And I'll start with Steve.
No, I don't. I think all forms of drug education and drug services generally are currently under-resourced. I'm going to talk about the Loop's work and drug checking specifically. I think perhaps in the next session.
We're coming.
But I think just as a general problem, and in a way it comes back to my introductory point, that because we have a culture of stigma around drug use, there is a sort of political reluctance to invest in harm reduction, and this has been a long-running sort of backdrop to all the discussions around service provision and harm reduction, going back to the 1980s, that there's somehow harm reduction is some kind of tacit approval for drugs, or it's condoning drug use, or it's sort of encouraging drug use. Now, there's no evidence to support that. In fact, there's plenty of evidence to refute that. But it still remains as a kind of sort of prevailing narrative thread through an awful lot of drug discussions, that somehow if we acknowledge that drug use is happening and try and encourage people to use drugs more safely rather than just to stop using drugs altogether, even though I think those two messages, they're not mutually exclusive, but harm reduction will somehow be encouraging drugs. And I think the problem with that message is that it takes place in this wider context of very polarized moral binaries about drugs being evil and drugs being wrong, and the drug debate generally has somewhat painted itself into a corner, that any retreat from these very binary, morally framed messages is somehow synonymous with weakness, or being soft on drugs, or being pro-drugs. Of course it's not. To my mind, we have to be pragmatic, and our starting point has to accept that whether we like it or not, whether we morally approve it or not, the reality is that millions of people do use drugs. That has to be our starting point. We have a responsibility to those people to keep them safe as well. But this all takes place in this very difficult legal context, because policy and law, by its nature, criminalises those people, and the political narratives around that make discussions of harm reduction very different, even now, 3 or 4 decades into the sort of harm reduction era.
Thank you. Neve, did you want to add anything?
Again, to echo Steve, I think the investment in drug education is woefully lacking. And Steve will talk more detail about drug checking, but part of drug checking is a brief intervention for folks around harm reduction.
We will be coming to drug checking when my colleague Emma starts asking questions.
My point, Caroline, is that for many people is the first time they've ever had a brief drug education session. Like throughout school, they've never had proper drug education. They start to use drugs and they haven't got the tools to try and make it as safe as an experience as possible. And in the 1990s, the City Drug Action team in London, along with Release and the Home Office, actually did a campaign called the London Dance Safety Campaign, which was fantastic. It went out and it educated nightclubs on how to make sure that you keep people safe whenever you identify that they've used drugs. Do you need to call in an ambulance? Is that appropriate response? How to educate people themselves. There was a tube campaign that highlighted, the different types of drugs, how to use them safely and the harms associated with them. It wasn't condoning drug use, it was trying to educate people. And that was a really effective way of raising people's knowledge. And that's all really we're talking about with the drug education programs, is raising people's knowledge to keep them to help them make good decisions. And I think just one last piece in this that may be useful from a city level is also the things around licensing of nightclubs. Often nightclubs will be required to take a zero tolerance approach in order to get their licenses, and this will be required through by the police locally, and then when the license hearing and application and process occurs. In those circumstances, we see very heavy-handed action at entries to clubs, which can lead to really dangerous, risky behaviour like preloading. So if someone's carrying some substances, often ecstasy, they will take a larger quantity than they intended to in order to avoid detection. And that can lead to real harm for the individual. So I think there is a piece around licensing and guidance for police and nightclubs to work together to try and support a harm reduction approach, both at entry and into the club itself.
Well, it's really interesting you raise that. It's literally because of conversations I had a few years ago with Fabric Nightclub after there were issues around their licence in Islington, where I'm a councillor, that actually made me want to raise this topic up when I found myself on the health committee, because it's kind of the what they described was exactly what you've just been talking about, the risk of people adopting more risky behaviour when there's a very heavy-handed policing approach. And it's how do you navigate your way through that when you've got licensing and policing issues, and for a club you want to keep people safe.
Absolutely, and it's certainly what the clubs want to do, is to provide great harm reduction advice and keep their customers and clientele safe whilst they're on the premises.
In terms of drug-related deaths from recreational drug consumption, do you feel there's adequate awareness of the associated risks, and do you feel there are sufficient measures in place to tackle what may be a growing problem?
No. That's my straightforward answer to that. No, as I said, I think what we need to do is have education campaigns. We need to tell young people how to be safe. Again, I know we're coming on to drug checking, but that is definitely an intervention that needs to be supported apart from the drug checking, and maybe we will bring this up, but there are other tests, reagent tests that clubs could use, that universities could use. There's a whole piece of work that we're doing at Release with universities across the country to really focus in on having harm reduction advice on site, but also recognising the legal obligations and limitations that are caused by the Misuse of Drugs Act, and helping universities navigate those to ensure that they are not committing offences, but also that we are giving them a proper assessment of how the legislation works in order for them to navigate that. So I think there are different spaces that we could encourage this kind of education approach. It should be citywide, but we could target in on, as I said, universities, nightclubs, the whole piece in secondary schools, etc., and younger. What I would say about education, though, like obviously with recreational drug use, it is really important that we give those, safer use messages. We should be giving safer use messages across all drugs consumption, all different types of drugs. But one of the things that when we talk about dependency is we have to recognise that a lot of the people who go on to become drug dependent have suffered a level of trauma, and that's often, abandonment, child physical abuse as children, sexual abuse, a range of horrific things have happened to them. And they're using drugs such as heroin and crack cocaine to alleviate that emotional trauma. So as part of the education piece and as part of the kind of engaging young people, we should be looking at trauma counselling from primary school. Like if we want to prevent long-term drug-dependent behaviours, we should be tackling the issues right when they happen, and that's the kind of like educational piece that we would see, intensive support for those who need it. And then obviously we shouldn't encourage people to go out and use drugs, and certainly not children, but giving them the tools and the resilience to know how to find that information and get that information in a way that is useful and reduces those harms.
Thank you. Steve, did you want to add anything in, and particularly on the recreational drug consumption?
I think that the main point I would say is that I don't think there's any real mystery here about what works and doesn't work. There's a large body of expertise. There's superb resources have been produced by the Advisory Council on the Misuse of Drugs, the government's own expert advisory group, which two of our speakers have been part of. The European Monitoring Centre on Drugs and Drug Addiction produces excellent resources on these things. Even the UN Office on Drugs and Crime and the World Health Organization have produced excellent resources on recreational and more problematic forms of drug use, in terms of prevention, in terms of service provision, and in terms of harm reduction. The question is, why that expertise and that knowledge of best practice isn't being implemented. And I think that's two things. One is a resource issue, and one is an issue of the political climate that I've already spoken to. We know what works. The reasons those things aren't happening are political decisions. They're not an absence of knowledge.
Thank you. I'm now going to move on to... Oh, Emma, did you want to come in on this
Yes, please.
issue? Yes.
Shall I come in and then?
Yeah.
Yeah, thank you. Good morning, all. Just wanted to pick up the fact that 6 months ago, the Mayor of London announced a London Drugs Commission, and we haven't heard much about it since. So I wanted to know if any of the panel members have been approached about that as a first question.
Not until today. So it's not something that I personally have been approached about, but my role is a national role, so it may be because of that.
I have approached MOPAC.
Okay.
So I'm in email exchange with MOPAC. I, apart from saying we would like to be part of the commission or feed into the commission, I haven't had confirmation of it starting yet.
Yeah. Same here. Well, we approached them, and there's a seemingly open door, but yet to walk through. I understand the focus is going to be more on cannabis-related issues.
This is going to be, I don't know if Steve...
Remember, you've got Alex on
Yes, I was going to
screen.
say, I didn't know if Alex wanted to come in, but that was going to be the second question.
I've not been approached, and I don't know what the position of that really is.
Okay, thanks. That's really helpful. So just two follow-up questions really for the entire panel. Firstly, and we just started, Steve, on that question, is how important is it to get this moving now? Obviously, we're 6 months since the commission was announced, but to my mind, perhaps people haven't been approached. So how important is it really that we get this moving? And secondly, on the point around there's been a lot of perhaps, and I'm not sure whether it's media or political focus on cannabis, how important is it that this London Drugs Commission takes a holistic view of, you know, the entire drugs picture in London?
So in terms of cannabis, I think cannabis is an important part of the picture that we do have to look at. And the main reason for that actually is around the policing of drugs in the city, and the fact that it is regularly 60% of all stop and searches, sometimes 70% of all stop and searches that are for drugs. We know from research that we have done at my organisation, but also from Her Majesty's Inspector on Constabulary, that that is largely drug possession offences, and we know that the majority of that is a cannabis possession. So I think we estimate something like 3 in 5 searches are for cannabis possession. So that's, and the fact that most don't result in any drugs being found, and that they disproportionately impact on the black community, especially young black men, creating a level of distrust in the police and in the system more broadly, is a really important part of the piece. However, I think a holistic approach would be really the focus of what the Commission should look at. And the reason I say that is obviously we are, as this committee is aware, in the middle of a drug deaths crisis, but also too we've seen problems in the supply chain in recent weeks and months around the availability of heroin, and heroin being contaminated with synthetic opioids. So isotoniticine, which is a synthetic opioid similar to fentanyl, which resulted in the deaths of, we're not absolutely clear yet, but we think 16 Londoners over a 7-day period. That, if that becomes the norm, we are in a crisis situation, and we should not be looking at solutions after this event happens. We should be looking at solutions that are preventative or that can respond quickly when it happens, because I have to say it was very challenging getting responses from just getting a coordinated response at an early stage with this. And I understand why, because you don't want to put out false information, etc. But I think there's a whole strategy that could be put in place around testing for this substance, both with reagent testings, which are strips that we use to test for the presence of a drug, also drug checking, which we'll talk about, but also a lot of the other things that we've been talking about in terms of access to treatment. So for me, it's really important that the Commission takes a holistic approach.
I'm just mindful of time. We're going into a whole extra area of questioning. So,
sorry, yeah. So shall I move on to
do you want to
drug
move
checking
on
services?
to the drug checking services? That would be great.
Thanks. And first to Steve, please. Could you explain what drug checking services are and how they work?
Yes, I can. There's not a single type of drug checking. There are a number of different types of service that can exist that serve different needs and different populations of users. I'm speaking on behalf of The Loop, who began their work in 2013 working behind the scenes with police and Home Office, testing drugs that were provided from amnesty bins or from police seizures, as more of a sort of research to sort of analyse drug markets, and on occasion provide information to emergency service and service providers about certain drugs of concern that were within markets. In 2016, that changed when they did their first drug checking service at a festival. In fact, 2 festivals that summer, Secret Garden Party and Kendall Calling. And what happens in that context is that individuals can bring a substance of concern. They will drop it off in a locked box and get a sort of ticket number, and then after a given period of time, between an hour, half an hour, and or sometimes a little bit longer, depending on the testing that's needed, they can come back and they can receive the results of the testing. And a condition of receiving those results is that they also have this brief intervention with a trained counsellor who will give them health and harm reduction advice tailored for their particular needs, in terms of the individual, the type of behaviours that they're reporting that they're engaging in, and the drug testing result. The testing is done by volunteers, but they're all PhD level chemists. And the interventions are delivered again by volunteers, but they're all trained drug counsellors. The testing involves a range of technologies, including FTIR, laser, Bruker analysis machines. There is a range of different technologies available, and it will depend on the particular setup. But generally, for the Loop, as a minimum, they use these laser FTIR machines. They basically shine a light through the drug. A particular kind of pattern of light refraction is then interpreted and related to a database of over 3,000 different drugs, so that whatever drug is in the sample can be identified, and if there are multiple drugs in the sample, that can also be identified. It's very clever technology. As new drugs are discovered, they will be added to the database. So things like emerging NPS, for example, when they're identified, they'll be added to the database. That's the basic setup, but that is really the model that would happen at festivals, for example, or events. You can also have drug testing as part of a drug service provider. So a drug service provider that deals more with problematic users or people who are street drug users could access the service to test drugs before they inject or smoke them, for example. And in some places, a drug checking service is available as part of a drug consumption facility, supervised drug consumption facility. I know that's something we're going to be talking about later. But drug checking and drug consumption facilities often go together. So I visited one in Copenhagen, for example, where there is a supervised injecting facility, but it also has drug checking on site so that people, before they inject their drugs, can have them tested so they know what's in them. Now, the kind of information that it provides is not just the nature of the drug. It can also provide information. Testing can also provide information on potency and strength. We know that any drug use is potentially risky, but that those risks are significantly increased when there are unknown drugs, if a drug has been missold, so it's not what is expected, or if there are adulterants present, or if there is unknown potency and strength. And one of the things that the Loop found, for example, in their very first festival testing at Secret Garden Party, was that whilst most of the drugs that were brought forward as MDMA ecstasy were actually MDMA ecstasy, the potency ranged from 20 milligrams to over 200 milligrams. So there was a tenfold difference in potency between individual pills. And again, to illustrate the sort of problems that you can face, it's not just unknown potency, it's unknown content. So the testing that the Loop did this year, very recently, only a few weeks ago, there was one type of pill called a pharaoh, it's the sort of shape of a pharaoh's head, because the pills, for whatever reason, tend to be branded with logos or certain faces or characteristics. And there were 4 different types of drugs, 4 entirely different drugs were being sold using this same pharaoh press. So again, drugs are risky, but if you don't know what it is or how strong it is, those risks are inevitably magnified. I mean, I can go into more of the detail about the outcomes in terms of the positive results that the Loop's testing has had, or any questions you might have about the other details. And I can also submit some stuff in writing if you want more
Don't
details.
worry, I've got lots more questions to come. So.
Okay.
But I did just wonder on that one point, when something's tested and essentially this is rat poison, it's not going to be great for you. Mm-hmm. How do you convey that? Do you or the tester, do they have to still give back that drug if they're like, I'm seriously concerned that this?
Yes, well, no drugs are returned to the service user, just to be clear. The drugs are destroyed in the testing process, and any remnants that are left over are either destroyed or passed to the police at the end of the day. So there's no the actual, and the drug testing is then entirely separate and independent from the actual service user, who then just receives the information and nothing in writing either. They receive the information as part of a brief intervention, and they're welcome to bring their friends and peers into those interventions as well. The Loop has found that when people are told that what they're having tested is not what they expected, half of them will dispose of the drugs. And in fact, one of the things that the Loop do is they offer a drug disposal service. So it's not just the drug that was tested is destroyed. People, if they say they bought 5 pills for them and their friends, and they test one and it's not what they're expecting, and it's something potentially very risky, they will often dispose of all of them. So this is one of the benefits of the Loop, is that it's not just the individual, it's often the individual's peer group as well. So there's a sort of magnifying effect that helps to actually remove some of these dangerous substances, the particularly dangerous substances of concern, from circulation. One of the other things that the Loop does is if substances of concern are identified, so for example at Park Life, when I mentioned the pharaohs, these pharaoh pills, there's a drug called Utilone, which is a fairly obscure cathinone novel psychoactive substances, which has some ecstasy-like effects, was being sold as ecstasy, but it is particularly risky. And it can cause paranoia and psychosis, and it's a major concern. They were able to not only help remove some of those pills from circulation, not only educate the people at the festival that these were in circulation, this was a risk that they needed to be mindful of, they were also able to inform the police and inform the other emergency services that these were in circulation. It was something to look out for. So they can help the preparedness of other services as well. So they provide a secondary tier backup service as well as the information that's given to users. Sorry, I'm not sure whether I answered your question there.
I think you did, and I think we're straight into the next one as well. So you may want to just embellish slightly more, but how could drug checking services help reduce deaths in London?
Well, I mean, it comes back to the point I was making, that there are these different types of drug checking services. So for what you might, I mean, you've referred to the term recreational, but the sort of nighttime economy. So we're talking about party drug use, mostly stimulants, cocaine, MDMA significantly, but also amphetamines, various cathinone type drugs and NPS are being used. Obviously, you can reduce risk if people know what they are taking. It's not just, young people, they don't have a death wish. They don't want to take unnecessary risks. They do have agency. If you give them the right information, both about what they're taking and about how to manage their drug use and behaviours, they do act on it. No young people want to die. No young people want to end up in an ambulance on their way to hospital. They do use harm reduction information, they do share harm reduction information amongst themselves, but they need to have access to that harm reduction information, and they need to have access to knowledge about what they're taking. So drug testing for that group of people is proven to be very useful. And it's not just from the UK. There are a number of countries that have been doing this for a long time. Austria and the Netherlands have been doing drug checking services for nearly 30 years. So we have a significant body of evidence. In the Netherlands, for example, there are 26 or so centres in towns and cities across the Netherlands where you can drop in, you can get your drugs tested during the week, so that you know what they are, and you get this harm reduction information so that when you take them at the weekend, you're much better prepared to manage your risks. And drug-related deaths amongst that population of users, particularly at festivals and in nightclubs, are almost unheard of in the Netherlands. They're a regular feature of the summer festival season, and unfortunately clubs more generally in the UK. I mean, I don't need to tell you about these tragedies that seem to come up every few weeks or months, particularly in the summer. Almost never happens in the Netherlands. So we can reduce drug-related deaths for those populations. And for the populations of more problematic users, people who are injecting or smoking, Neve's already alluded to this, that there are these genuine concerns on the horizon that the heroin market in particular will be contaminated with some of these very potent synthetic opioids like fentanyl and isotretinoin, I'm not even sure how to pronounce it, it's so new, that come along regularly. It's not just fentanyl, there are many different analogues of fentanyl. And fentanyl is 50 to 100 times stronger than heroin and morphine, and carfentanil and some remifentanil. Some of these, they can be thousands of times more strong than heroin. So a tiny dot of this stuff is still enough to cause an overdose death. Now we need to be mindful of this. We know how to prevent deaths from these drugs by providing testing services. So that if people have these substances mixed with their heroin, or they've been missold these substances as heroin, they are able to make informed decisions about how they use them. But if we don't have testing services and if we don't have supervised consumption, we can't do those things, or they become a lot more difficult. And we know these things can reduce deaths. We just need to put these services in place.
Steve, and what are the key concerns that often come up and are associated with the implementation of drug checking services? And you've mentioned obviously Netherlands and Austria there. Might want to talk about how they've overcome those concerns and shown.
I mean, there is a concern, something I've already alluded to, that if you make drug use safer, you're somehow encouraging or condoning that use. That if you make these services available, use will increase. And again, I think it's really important to be clear that there's just no evidence that that's the case. We have no evidence that drug testing services increase use. And actually, one of the Loop's findings was that, because of the brief intervention, where you can explain to people about dosage, about risks, about how to manage their dosage, and how increased dosage is associated with increased risk, that 2 out of 5 people who've used the Loop services actually moderate their levels of use, and they share that knowledge with their friends who also moderate their levels of use. And even when the Loop have done follow-up surveys 3 months later with people who've used the Loop services, those people are still moderating their risk behaviours, not just in terms of dosage, but in terms of mixing drugs. Because again, one of the risk factors for drugs is if you mix different drugs together, you magnify the risk up. But these are things, if you educate people about those risks, they will tend to moderate their behaviours. Because like I say, nobody wants to die, nobody wants to go to hospital. They want to have fun. I mean, people take drugs for pleasure. We need to not deny that fact. Young people can be hedonistic, but that's the reality. They like to go out and drink. They like to go out and sometimes take illegal drugs. We have a responsibility to help manage their use, and knowledge is power. You give people the ability to make informed decisions by knowing what they're taking and knowing about how to manage their risks. And it's unsurprising that they do use that information and do manage their risk in responsible ways. And the Loop and drug testing services are a particularly useful way of facilitating that. As Neve's mentioned, one of the striking findings about the loop is that 90% of the people who've used the loop services have never encountered a drug professional or engaged with a drug service before. So these are an often quite vulnerable group of young people, often novice drug users, people who haven't used drugs before, don't really know what they're doing, who are getting information, important, potentially life-saving information from professionals that they wouldn't be otherwise. They're a hard-to-reach community of people who are at risk, and the loop and drug testing services provide this vital doorway to access them with this potentially life-saving information.
So one of the key concerns being that drug use will increase, but that would be a good mitigation argument against that. But I think perhaps in London, one of the concerns people raise is how work with the sensitivities with the Met. How will the Met accept this? So, for example, if I'm travelling to East London on a night out in West London, but I'm going to use a drug testing service before then. That's a long journey, for example, where you are carrying illegal drugs. And how do you work with the Met if you were to use the services more within London?
Well, I mean, interestingly enough, a lot of the impetus for drug testing services has come from the police in terms of, and the Loop has worked very closely with the police. The police, in different police authorities around the country, I'm not talking about the Met at this point, but the police, they have to balance their need to enforce the drug laws against their responsibilities to protect the people in their care, and particularly in certain environments like festival environments. The police are fully aware that a significant proportion of people most people will be drinking, but a lot of people will be using illegal drugs. A lot of electronic music event type festivals, according to some of the research that Fiona Measham's done, you often have more than half of the people will be using illegal drugs. Sometimes it's over 2/3 will be using illegal drugs. Now, the police know that, and they don't want people to die. I mean, I've spoken to police who've been working at festivals where people have died, and these police are devastated. They feel like they've failed. And they are the ones often who are the keenest to have these services available because they know they work. And nobody wants young people dying at festivals, events, nightclubs, or anywhere else. So the police have often been very supportive of these type of interventions. It hasn't happened yet in London. Maybe there's some political reluctance on the part of the Met. There are certainly some people in the Met who've been very supportive, others not so much. Maybe some of the political swirling currents around the drug debate are more intensely felt in London, but I think there is a profound need for this sort of services in London. I mean, you talk about the size of London. Yes, it's London is 2 or 3 times the size of the whole Netherlands, so there's an open question about how you would provide these services. One drop-in place in London would not be enough. You would need multiple centres, multiple services, and probably a range of different types of services. Static services, maybe some pop-up mobile type services based in drug service providers, or for dealing with different using populations. But it is something that needs to happen, and generally speaking, I don't think the police are the big obstacle here. They can be. There are political policing difficulties, but I don't think they're insurmountable. And in many cases, the police have been leading the push for these services. And I think it's important to stress that the police aren't an enemy of harm reduction for the most part.
I think that's clearly the key, isn't it? Though, is making sure that you send that message that the Met are happy, and that, we can work together on this. But the other where I was interested in you could work with the Met would be perhaps with those people that perhaps are arrested and drug users, testing substances that may be found on them, even if it's not a drug-related crime that they've been arrested for, and perhaps having that intervention. Is there any way that you could work more closely with the Met to do that sort of service?
Yeah, I mean, I think so. I mean, maybe Neve could come in on this. I mean, I think that how the police deal with people who are caught in possession of drugs more broadly is a big question. we already have a number of police authorities around the country who are implementing what are called diversion programs, so that people who are caught in possession of drugs, rather than being sort of processed through the criminal justice system and being prosecuted and getting criminal records, are diverted into health programs, a range of health programs. Now, these diversion programs, they have different complexion in different police authorities, so it's quite hard to generalise, but on the whole, the idea of it is that people who are caught in possession, particularly people whose use may be problematic, are diverted into the relevant services or education or drug education programs rather than getting a criminal record. And again, the police are leading on this because they know from their own frontline experience that continually arresting and prosecuting people, particularly vulnerable, marginalised communities, is generally counterproductive. It's a drain on their resources, and it doesn't help the individuals or communities. They know that health interventions are more effective than punishment and criminalisation. So that is already a trend that is happening in the UK. I don't think we have diversion programmes in London yet, but hopefully it's something that will be happening more. And actually, although some of the rhetoric we get from the government may seem hostile to such interventions, actually in many cases the government's quite supportive. Kit Malthouse has been very supportive of the Durham Checkpoint diversion programme. The ADA, the quite high profile government ADA programme, one of the D's in ADA is diversion. So the government is actually quite supportive of diversion, as are the National Police Chiefs Council, who have been very active in this debate and are sort of approving of what's been going on in these various police. I think it's 12 police authorities. Scotland announced it recently, that they're going to be diverting people caught, including with Class A drugs. So as a general shift in that direction, that is already happening. And I think that general shift helps facilitate all these other interventions, whether it's drug checking, whether it's supervised drug consumption services. It's all facilitated and enabled by generally reducing the burden of criminality that we place on people who use drugs more broadly. So there does seem to be a general move in that direction, but it's also, I think, fair to say that London is not leading the charge, and in some degrees, I think, is dragging its feet.
Thanks. Just to give you a small breather, going to turn to Alex for the next question, if you can hear, Alex. Just wondering, what policy changes or guidance would be required for drug checking services to be implemented or trialled in London? Which stakeholders would need to be involved, and where could they be located?
Questions. There's a number of stakeholders that would need to be put together, and this is something that Luke and Fiona Mission worked on assiduously over the last few years in building those partnerships between the local authorities, including the Public Health Department, the local police force, local drug treatment providers, and the people who would be doing the testing. In the Luke's case, it's been their own volunteers, as Steve's been saying. There are some legal challenges that need to be addressed, because obviously the people using these services will be breaking the current law by being in possession of substances that are controlled under the Misuse of Drugs Act. But that is a legal challenge that's often faced by services that work in the drug field. For example, needle and syringe programs, people who are housing people who are dependent on these substances. So that's certainly not an insurmountable legal obstacle to the provision of drug checking services or any other harm reduction service.
Thank you. And perhaps other members of the panel might want to come in. You might want to pick this one up again, Alex. But what are the main barriers to drug checking services being implemented or trialled in London? And perhaps you might want to speak about funding or funding models under this as well.
Is that for Alex?
Alex or Steve, but
I can speak to that. The services aren't cheap, but they are cost effective. If you look at the costs of dealing with drug-related emergencies that would be avoided, as with so many drug service and harm reduction interventions, looked at overall, they are very much a cost-effective intervention. At the moment, the Loop is operating on a shoestring. They have 400 volunteers who are all either professional trained counsellors or PhD level chemists who work for no money at all. Their budget's very modest, and they are not going to be able to roll out these services. Anyway, I know the Loop wouldn't be providing services for the whole of London or for the whole of the UK, but they're struggling to expand and because they don't have any money. I think it's of note that in the Netherlands, the government pays €1 million a year to provide these services across the country. We don't have anything like that in the UK. We have very high levels of drug deaths, and they don't in the Netherlands. I think there's a fairly obvious lesson there. So funding is a major resource barrier that we need central funding to provide these services, or local funding.
I imagine it might be there's a clear social impact bond kind of model there, really, where between councils and the GLA and central government, because you can see real tangible benefit, perhaps.
Yeah, absolutely.
Okay, and just a final question, I guess, best to direct towards you, Steve, is how important do you think it is that drug checking services are included in the discussion of the London Drugs Commission?
I mean, I think that absolutely. I mean, I would be surprised and disappointed if it wasn't one of your recommendations and one of the London Drugs Commission's recommendations. I'm not quite sure how the two sets of inquiries.
We're a scrutiny body. We check the mayor's doing a good job, so we'll be looking at his drug commission and scrutinising it. So this hearing is to inform our position.
Okay. Well, I hope that that you recommend drug checking services. I hope that the mayor supports that. We are beyond the pilot point here. There are hundreds of drug checking services across Europe and across the world. They've been piloted in the UK, both at festivals and events and in city centres. So, I think we do need to have some static service-based drop-in type services in London, as well as mobile event-based services, and as well as drug checking services based in services for people who inject or smoke drugs. I can't see any reason why that can't be implemented very quickly. There is some political barriers, but they're not that serious. The Home Office ministers have said in Parliament, and I can provide you these quotes if you're interested, on a number of occasions that they're not standing in the way of this. That's the actual language they've used. We are not standing in the way of this. This is a local decision for police and health authorities and service providers. So there are some legal challenges around this, but they're not insurmountable, and the Home Office is not dead set against this. There are some harm reduction innovations where there's a lot of hostility in the Home Office. This really isn't one of them. The Home Office has done a licence for a pilot drug testing service that was based in Weston-super-Mare. This is not new territory. So the political obstacles are modest. The legal obstacles are negotiable. Resource obstacles is a major one. But really, this is about political will. It should happen, it can happen, and I hope it happens as soon as possible.
Thank you.
I've got Krupesh first, and then Andrew.
So I was going to end there, but I thought one thing you said was really important to pick up is the recommendation, perhaps, that you said, Steve, is not that we should be trialling in London, but we should be commissioning in London. And I think that's a very important difference.
I have written down we are beyond the pilot point.
Okay, perfect. Thank you.
So I have very much picked up on that point.
Done pilots, we know they work. We're not doing pilots.
So anyway, Krupesh, you wanted to come in.
I just want to throw in another barrier, actually, sadly, because you mentioned about the political barriers, but do you find that geography is also a barrier in London when it comes to prevention as well? One of the things that I've always found is sort of my previous hat was a cabinet member in Brent for public health, and a lot of the burden in terms of providing the services, venues, treatments fall on central London because that's where a lot of the drug activity takes place statistically. And I just wonder if that's also a barrier that you found as well, and how we can overcome that And do you find that when you're looking at other cities such as Manchester, you've got one council, one citywide kind of centre, it's a lot easier than dealing with the 32 plus City of London boroughs that we have in London? And do you feel there's a case for more London-wide public health prevention powers and budgets?
I would generally agree with your points on that. I think I'd probably pass on to people. I'd pass on to some of my colleagues who've dealt with the Met more on service provision.
Yeah, I mean, I completely think there's an argument to have a pan-London funding and policy approach in this area, not least for the reasons that you said, but also I'll go back to my earlier point about the isotretinoin deaths that we had in August. I mean, it wasn't just the deaths, it was the hospitalisations of people who overdosed, thankfully not fatally, which was in the dozens. And imagine the cost of that to hospitals across the city. So again, if we're thinking about a strategic approach to responding to crises, that's the kind of thing a pan-London approach could take.
You mean when there's a crisis with a drug that's
that's
not what people think it is, and that's causing harm amongst users?
Absolutely, and as Steve said, I think we expect that the market may get disrupted even more in the coming months and years. We don't know what will happen in Afghanistan with the production of opium. We just don't. And so in that sense, I think it's really important to have those pilots in place, and because we won't know, will that happen in Brent? Will it happen in Lambeth? So this is the kind of thing that you want to have a coordinated approach across the city with both the support for the facilities and the funding for it. But that's also, I guess, a longer term approach to funding. There's nothing stopping boroughs getting together at the moment and talking about how do we do this in a coordinated way. And I think the Assembly could possibly facilitate some of those conversations at a more local level, which would be great.
Certainly this last 18 months has seen massive coordination in terms of public health across London. So actually that's something where we could learn from that way of working.
Absolutely. When public health people have been in charge, things seem to have gone pretty well, and maybe not quite so well when central government's been doing things. Just a little dig there, but genuinely, the public health people is where the expertise in this sort of coordinated service provision sits, and absolutely they should be the ones who are coordinating sharing of information, sharing of best practice, and responsible allocation of budget as to the needs in different boroughs. I've worked in other countries on some of these issues. A place like Norway, I think Norway's got a population of about 4 million people. So London's 2 or 3 times the size of the entirety of Norway, but Norway has all these. So it's a vast challenge for London. But yeah, on your general point, absolutely support and agree with what you're saying.
Thank you, Krupesh. Andrew, I was going to bring you in anyway to move us on to our next section, which is looking at naloxone. But you've got something you want to come in on the back of Emma's question.
Just a quick finish off on that one. Do you think it's possible to provide drug checking services without the support or consent of the police?
No, not really. On a very small scale, informally. People can buy sort of home testing kits, but the information you get from them is fairly limited. I think really all of the drug testing that the Loop's done has been working with local police. I don't think they've ever done it without consent. So essentially no. But the police, as I said, have generally been very supportive. Not in every single situation, but more often than not, certainly where the Loop's been concerned, the police have been behind the provision and have facilitated that provision.
I would just quickly add it's an education piece with the police. The police are already doing that, as I think Alex mentioned, around needle and exchange provision within drug treatment services and harm reduction facilities. So we expect that people who are accessing those facilities are in possession of substances, and in fact the Crown Prosecution Service has acknowledged that and has specific guidance in place that says that in relation to these facilities, that the users of the facilities and the staff of the facilities will be necessarily in contravention of certain sections of the Misuse of Drugs Act, but because of the public health argument around reducing BBVs and HIV in particular, it's not in the public interest to pursue folks accessing the service. So we've got a kind of template for that the police are very used to policing. So there's no, it's just about making them realise that they're already doing it.
I'm just concerned about the protocols. If you're going to set up a fixed drug checking service, obviously people are going to be going to it and leaving it as well. And unless there's sensitive policing that takes that into account, I would have thought possibly the drugs checking service wouldn't really work if somebody thought they were going to be arrested.
The police have got to be on. They've got to be on board with it. But like I say, we do have working precedents for that with other drug services. So I don't think it's beyond the realm of possibility.
I just wondered if Alex wanted to come in on this one.
Yes, of course.
Just please, everyone, keep remembering we have Alex remotely.
Yeah.
For the reminder, Chair, that me and Steve have covered everything I would have said.
Okay.
Right. Thank you.
Just didn't want you to feel left out.
We're now going to move on to naloxone. Could I just ask Dr. Bijral and Ms. Eastwood, how could a wider rollout of naloxone help to reduce drug deaths in London? Perhaps Dr. Bijral first.
Thank you very much. So just briefly, what naloxone is, it's effectively an opioid overdose antidote. So if somebody was to take something like heroin or another opioid and they took too much and they overdosed, what's happening in the body is that the brain is being told you don't need to breathe, so people stop breathing and hence they die because of that. What naloxone does is reverses the effect of that and then hence can bring people back to life. It's a drug that's used across the country in A&E settings, ambulance settings for many, many years. It's a very old drug. And then in the last a number of years, it's been made more available for community purposes. So that is naloxone, take-home naloxone, so a kit. So I've got my kit for naloxone that I carry with me wherever I go. Should I pass somebody who may be experiencing an overdose and that could die, so that I could, in my capacity as a citizen, but also somebody who's trained to use naloxone, which is actually really easy to get trained, and I would encourage anybody here to look into it. I could provide life-saving intervention for that person and save a life for almost no trouble, almost no cost, and a life is saved. So what we're dealing with is the end result of not being able to help people get into treatment for all the reasons that we've talked about before. This is essentially failure demand, where we're meeting people at the end of their journey or their journey at that time. Ideally, we would have liked to have helped people not have an overdose, but we are where we are. So this is to help people who have had an overdose survive that overdose. As a health and social care provider, we provide many, tens of thousands of kits of naloxone across the country. So we've seen firsthand, the evidence is already very good that if you provide naloxone to people, you are going to be saving lives. But we've seen from our own experience, when the naloxone kits are used, and when because we ask the question, people come back to return to get new kits, for example. We ask, has it been used? And it's been used to save lives.
You go on about the evidence is already very good. I put a question to the Mayor back in 2019, and his reply was, we're waiting on the evidence to see whether or not police officers should carry it. And now, most recent question, he's now saying, we're waiting to see what happens in the West Midlands.
Yeah.
But you're saying the evidence is already there.
I should say, naloxone's a slightly unusual one compared to, say, many other drugs. The way evidence is established for most medications is through trials. So you do a trial to establish safety, effectiveness of a medication. You can't do that with something like naloxone. You can't give naloxone in a kit and a placebo in another kit and then see which one's going to be effective when somebody's overdosing. You can't do that. It's not ethical, obviously. So the evidence that I'm talking about is from real-world evidence of people overdosing and then being provided naloxone. The West Midlands pilot you're talking about is also, we provide services in Birmingham as one of the West Midlands areas. And naloxone more recently has become available in a nasal form. Now, that's quite important because I think it improves acceptability. So this is people's, I suppose, comfort with carrying a medication or something that they could use. I'm a doctor. It's relatively easy for me to give somebody an injection, as it is for many people. Some people might struggle with that. And I know the police actually nationally had a number of issues with actually their staff actually carrying needles because of needle stick injuries, other things like that. But the West Midlands pilot, the naloxone has been used, nasal naloxone, to save lives. As it stands, that evidence is developing, but we know lives are being saved by first responders, by the emergency services, police, not just police, we're talking about coast guards, we're talking about the probation hostels. They're not called that now, they're called something else, I can't remember. But, areas where there's high risk of people coming out of prison, for example, who are in a slightly less than stable environment. We know that there are areas and there are colleagues across the sector who are more likely to come into contact with people that may have had an overdose. And in those cases, you want them to have naloxone because that's going to buy them that time. Say, well, we already know about the situation with ambulances and emergency service. Everyone's really, really stretched. If you can buy them that time to give them naloxone, then what you're doing is that person can then breathe again, their brain can get oxygen, they're more likely to survive, they're less likely to suffer long-term side effects of, say, brain damage or other things, even if people do survive. And I can't tell you the cost of naloxone, I should know this probably, but it's not expensive.
Ms. Eastwood, have you anything to add on to that?
Not in any huge detail except to say we set up a working group in 2018 with the King's College Centre for Addiction with John Strang, Professor John Strang, who is the person on naloxone, if you like. And I think that working group, we produced a paper which we can share with the committee. It's called Saving Lives. And the basic premise is that there should be a presumption to supply this medication, this life-saving medication, in any setting where you come into contact with someone who's at risk of an overdose or who is likely to witness an overdose. And therefore, with that presumption, obviously, we have a high level of injecting drug use amongst the homeless population in London. Unfortunately, it's an increase of 135% over the last 5 years, with 144 people dying last year of a drug-related death. And those people will come into contact with law enforcement, so that presumption should be that they carry it. As I said, this was done jointly with the Addiction Centre at King's, but there are other settings that we should get it into as well with first responders. So A&E staff being able to give out naloxone to someone who has experienced an overdose and has come into their services.
I'm surprised you say that. Haven't A&E staff already got naloxone? So
they will administer it, but they won't necessarily supply a kit for someone to take home. So in terms of taking home that kit, so thinking about all the environments that we can focus on and getting supply out to folks who are at risk of overdose or who are likely to witness it. So I think there's a piece of work that we could do around that. So for example, Brighton and Hove have got a take-home naloxone programme in their A&E facility. So anyone who presents with an overdose is given a kit and a quick intervention on how to use it. More broadly is peer-led naloxone initiatives. So during COVID, as Prune has said, a lot of the services had to close their doors. They still did, as I said, significant work to get harm reduction equipment out there. But one of the ways they did that was to partner with peers. So people who have experience of using drugs, people who have experience of overdose, those who have witnessed overdose, and those who the community that they work with, that they represent, respect, listen to, and who have credibility. And this has been a really important initiative under COVID. I mean, I think we would be looking at a much worse situation with drug-related deaths had it not been for a number of those initiatives across the country. But they are woefully underfunded and they are woefully undervalued. And so that's really one of the things that I would like the committee to really focus on recommending, is this range of different actors, different groups that can get naloxone out into the community. One of the other things is GPs. So if a mum comes in and says, my son is using heroin, give her a naloxone kit, teach her how to use it. I mean, these are the things that we can do. It is incredibly cheap. It's about £20 for a naloxone kit. The nasal kit is a little bit more expensive, I think about £35–40. But this is a very, very cheap, easy to use intervention that can save lives. So I think we would say try and get it out into primary care, secondary care, and using peers to really reach the population who are not in contact with services.
I mean, it sounds like it should be a key concern to the night czar, for example, who, the nighttime economy czar.
Absolutely.
Who should be pushing on this. What are the it's difficult to understand what the concerns are about the further... Did you want to contribute, Professor Stevens?
So I just wanted to mention a particular important target group that is being underserved at the moment, which is people who are leaving prison. In 2019, the ACMD wrote a report on which I led on community custody transitions, and in that we confirmed the knowledge that the transition out of prison is a particularly risky time for drug-related death. The risk of death increases multiple times in the first few days and weeks after leaving prison for people who've got problems with heroin, largely because they lose tolerance while they're in prison, and if they take the same amount when they leave, then they're much more likely to die. And a good response to that is to give people who are leaving prison who've got a problem with heroin a naloxone kit so that it's available to use if they need it. But we found that only 12% of prisoners who've been assessed as having a problem with opioids were actually leaving prison with a naloxone kit. So it would be a pretty easy win to increase that proportion by making sure that people can have naloxone. The ACMD has also in the past recommended that when an intranasal rather than injected naloxone kit were available, which it is now, we should consider making naloxone available over the counter in chemists. At the moment, naloxone is prescription-only medicine. But given that the harms of naloxone are so minimal, we see no reason particularly that that should continue to apply to the intranasal preparation. So it would be useful to expand the provision of naloxone, the availability of naloxone to families and friends of people who are using heroin by allowing them to buy them in chemists.
This actually sort of segued nicely into my next question, which is, what are the concerns associated with the wider rollout of naloxone? I'm struggling to understand what's again it.
We're struggling too. I think one of the things that Alex has just mentioned is about the fact that it's a prescription-only medication. Now, historically, that has been because it's largely an injectable. The intramuscular version is injectable, and because it has a needle, that's one of the concerns. But it also, the nasal spray is also a prescription-only medication. The Department of Health are currently undertaking a consultation to look at widening the different actors who can supply naloxone. So currently it's prescription-only medication, but the exemption to that is if you are a drug treatment service and you are providing it to save a life, which is what you will always be providing it for. So if you have to be linked in with drug treatment services in order to supply. So they're trying to expand that range into homelessness services, all of those different environments where you have a likelihood or there is a high risk that the people that you're working with or who you support are likely to overdose. I think one of the concerns, which is a false concern in my view, is the idea that it encourages risky behaviour. So there has been a very poorly researched paper that was produced in the US that suggested the provision of naloxone led to people more likely to engage in risky injecting behaviours with their opioids. Alex can speak to this, but it's really just it's a straw man's argument.
Do you think we could therefore do with a sort of a wider public and professional understanding of naloxone?
Absolutely. We should definitely be supporting public campaigns on this. And in fact, Scottish Government has just commissioned and launched a campaign, both TV ads, posters on the transport system, encouraging people to carry naloxone, to administer naloxone. I mean, this is a really great medication. It's cheap and it saves a life, and we should be celebrating it. So anything that can promote the evidence base for it, but also the compassionate nature of it. Again, there's another campaign that was launched earlier in the year that has highlighted the experience of people who have administered naloxone and the positive impact of that. And again, I can share that with the committee. But yes, we do need to have a public information campaign across the city to encourage understanding, compassion and use.
Can I just check that we've noted that you're going to share that information?
Yes.
That sounds really helpful, thank you.
Wales and Scotland have a national naloxone provision programme. Do you think it would be beneficial for... actually, I don't even know why I'm saying this. I know what the answer is going to be. But it would be beneficial, would it not, for England to have a similar thing?
Absolutely. All of the other three countries have national naloxone programs. I think also too, the fact that it's devolved to local authorities to fund and support naloxone programs leads to a postcode lottery on availability. And we are still in a situation where and correct me if I'm wrong, Prune, but we're still not recording the number of naloxone kits dispensed by services at a central national level. Is that right?
Centrally, I think the only work done on that was actually the work you did.
And this is a really easy thing that government could track, and that Public Health England can track through the National Drug Treatment Monitoring System, is how many kits are you getting out there? It wouldn't be that hard, it wouldn't be that burdensome to drug services, but they're not doing that, so we don't know, whereas we do know in Scotland, Wales and Northern Ireland what's happening.
It wouldn't hurt for the Mayor to take the initiative and introduce it in London, which he has influence on the Met, which would enable him to do that, I'm assuming.
Yeah, and even if we started to do monitoring in London, that would be a really positive thing that gives us, the more information we have, the better we can be at getting this out into the communities and into the spaces they need.
And presumably even better if we could enlist the support of the blue light services to promote.
Absolutely.
Thank you. Sorry, a couple of members of the committee are suffering from this cold that's going around, so apologies for any hacking cough that you hear. Professor Stevens, do you think the Met should carry naloxone, and what are the main barriers for it being carried by first responders? Do you see any barriers?
Everybody who is likely to come across somebody who's overdosing from opioids should be carrying naloxone. And that includes police officers in areas where there is relatively high use of opioids and high levels of overdoses associated with them. Now, there's practical difficulties and there's attitudinal difficulties. So the practical difficulty is that police are obviously already carrying a lot of kit and don't necessarily want to add yet another thing onto their belt. But naloxone increasingly is provided in very portable packages. And even if it weren't provided on the policeman's belt, police officer's belt, it could be provided in every police patrol car without adding taking much of the space that's available in that car. I see no good reason practically why police shouldn't have at least quick access to naloxone, even if they're not always carrying it on their person. The attitudinal difficulty is a different issue, and there has been resistance, for example, from the Police Federation to the carrying of naloxone by police officers on the basis that police officers are not medical professionals and shouldn't necessarily get embroiled in medical emergencies. I think this is an argument that is rooted in stigma, because police officers I know are very willing to save people's lives when it comes to doing CPR or other first aid life-saving interventions. And naloxone is a first aid life-saving intervention. So I think we should argue strongly against the argument that naloxone is any different from any other first aid kit that people might have access to. And I think we should expand the use and carrying of naloxone by police officers across the country, including in the Metropolitan Police.
We've ploughed this furrow for quite a bit now in these questions, I think we've got probably everything that we need. Only one thing I'd ask, of course, the Mayor's set up the London Drugs Commission. Do you think they should consider naloxone, or should they just do it?
Just do it. I mean, I don't feel that that's part of a major debate at the minute, but it needs to be funded.
I think previously, when there were issues for the police in terms of occupational health and needle stick injuries and some of those complications, I could understand why it was a bit trickier. I think we've got opportunities now with the nasal naloxone to make it, like I said, more acceptable, easier to carry. Some people are uncomfortable with things like needles, understandably. So to have our police to be able to have something that they're comfortable with is only going to increase the chances of using the kit to begin with, but also trying to understand a bit more about it and seeing if it's something for them.
If the Mayor or the police were to come to any of you and ask for a cost-benefit analysis, because we've always got to think like the Treasury when we're talking about spending money, would you be able to provide such a thing? Would anybody?
In terms of the evidence, I mean, the consultation that's happening right now around naloxone, there's a huge wealth of evidence that's gone to support that, but I think we should be able to provide any evidence or information you require around the available evidence right now around naloxone. We have it all, practically, so yes.
Thank you very much. Thank you, Chair.
Thank you. Krupesh, you wanted to come in, and then you will be moving on to open up questions on drug consumption rooms, but if you want to do your follow-up on naloxone first.
Thank you. I think some of it's already been answered, but I just want to kind of get a picture maybe from you, Dr. Bidral, on the circumstances on when it's used. Would you expect the person to be completely unconscious, or?
So, yeah, absolutely. The thing that you're checking, I think what I was saying... Sorry, did you finish your question?
Yeah.
I was just... Opioids... people could take lots of different drugs at the same time, so it can be a bit tricky, but opioids particularly depress the respiratory system. They stop people breathing. So typically what you're looking for is if somebody's not moving, not breathing, and show signs of being low in oxygen, so their lips might be going pale or blue even, and it's those kind of signs which police and first responders see all the time. This is not something that they're unfamiliar with at all. In fact, I'd say that they are more likely to come across those circumstances than I would in a clinical setting. But that's what you're looking for. That's what they would respond to. So it's quite clear. There may be other complicating things in there, but I think, as we've said before, the actual medication itself is relatively harmless. There's not a lot of side effects to it. So on balance, you'd want to use that medication in those circumstances.
I think it's just worth chucking in here, and Prue, maybe you can back me up on this, but the naloxone is also effective for most of the synthetic opioids as well, I believe it.
Yes, it is. Theoretically, it is. Again, evidence is there isn't a huge amount of evidence around its relative effectiveness against things like fentanyl versus others, but it's still an opioid. You would still give an opioid blocker. There is anecdote that you may require slightly more or otherwise, and actually as a precaution, because we did some of the first work in the country around fentanyl prevalence and checking, because obviously that affects people who use our services. And as a precaution, we did recommend that if there were areas that we felt there may be increased risk of fentanyl being in the drug supply, or we had evidence that fentanyl was actually there through testing, drug testing, or point-of-care testing for people, then we were recommending carrying extra naloxone just in case. Again, that was a precaution more than anything.
Because it will do no harm to the individual to administer it. That's the most important
That's
thing.
an important thing to say.
Yeah, it will do absolutely no harm.
Yeah.
No, thank you. I think that kind of scraps my next line of questioning, which was just, if it was to mistakenly be given to someone who maybe didn't want it, but if they are completely unconscious, then I think we need to try and save that person's life. So I'll move on to drug consumption rooms, which is the next section and final section of the questions. So the first set of questions are directed to Niamh and Prune. Could you tell us what drug consumption rooms are and give your opinion on whether they would help to reduce drug deaths in London? If I turn to Niamh first, maybe.
Okay, so drug consumption rooms, there's over 100 of these facilities across the world, located in around 60 plus cities. They vary in the way that they operate. Some are highly medicalised, others are run by peers, so people who have a history of drug use, and it's a lesser of a kind of sterile environment. But at their core, what they are facilities for people to come and use their own substances, mainly injecting of opiates, so injecting heroin. Some will have smoking facilities for crack cocaine or cocaine use, but they really are targeting some of the most high-risk drug users and the most marginalised in our communities. The drug consumption happens under supervision. If someone overdoses, naloxone, which we've talked about, can be administered. It is also, at its primary core, what it aims to do is to reduce drug-related deaths, reduce overdoses, to reduce infection. I mentioned earlier about the situation with bacterial infections linked to injecting, that research that I referred to. On site, there will be people to provide wound care, so it reduces those infections, it reduces the risk of bloodborne viruses because sterile equipment is being provided, and so people are less likely to share that equipment. So those are the primary aims of the service for the individual. There's a broader aim of reducing sort of so-called public nuisance, so public injecting, etc. So that's the positive for the community. And then there's secondary aims of supporting people into services, whether that be treatment services or broader social services such as housing, etc. So it has a multi-layered approach in terms of positive benefits. To the question of whether it reduces overdose deaths, there is research from Canada. Vancouver opened its first facility in the early noughties, and in the first 2 years of the facility opening, there was a reduction in drug-related deaths. It was estimated at 35%. Now, I am going to refer to my colleague Alex Stevens because he is actually the chair of the Drug Consumption Working Group at Drug Science, which we are members of, who has been working proactively on this issue. But the research to date shows that it can reduce overdose deaths. That's both research from Vancouver and from Sydney.
If I could... Oh, sorry, were you going to Alex?
Yeah.
I was just going to add that, and in terms of the number of overdoses within, so they're called many things, aren't they?
Yeah.
So like safer injecting facilities, drug consumption rooms, many hundreds, thousands of overdose have been reversed, but people haven't died in these facilities across the world. So that's, that's also something to consider. I was very privileged to actually visit a drug consumption room in Copenhagen, the one you referenced, Steve, and met the multidisciplinary team who supported the people who used that service. And interestingly, it was a purpose-built facility directly opposite one of Copenhagen's largest police forces. So they worked in partnership to support the people that use that service. And speaking to the the social workers, the nurses, the doctors, the GPs actually who worked in the service. And I asked the same question, what is it for? What do you actually do? And they boiled it down to it's to bring people inside, people that are in alleyways, terrible situations, in the cold, trying to find a vein in the middle of winter, and Copenhagen's freezing in the winter. It's very, very difficult. So you're going to go and try and access the most high-risk areas to inject. It's to bring people inside. And ultimately, while it's not necessarily the aim of the facility, if we were to do something like that in the UK, and actually some people have set up mobile facilities, Peter Crikant up in Scotland, actually what we'd also be hoping for as treatment providers is actually these are people that are not in treatment. For whatever reason, they're not accessing that evidence-based structured treatment. That's no judgment on them. But at least it's another opportunity perhaps to say that, we'll help you with what your needs are right now. And maybe you want a bit more of a chat about what else we could provide or support you with. It's another opportunity to access people that we won't get to otherwise.
Yeah, and on that, does that require a different legal framework?
The legality of the DCR, I will defer to Alex on this one, but it is a tricky one for sure.
I'll talk about the legality. I'd also like to come back to the evidence base, if that's all right.
Yeah.
So the Home Office claims, and Home Office ministers have claimed, that it would be illegal to run such a site in the UK. And that is an arguable case. And I think drug consumption rooms in this country would exist in a legal grey area, because it is obviously true that people who are using these services would be committing the criminal offence of possession of a substance that's controlled under the Misuse of Drugs Act. But as we talked about in relation to drug tracking services, that should not necessarily be a barrier to the provision of such a service, because those legal issues have been dealt with before in other settings, primarily needle and syringe programs. So the question then becomes, does the running of a drug consumption room involve other offences? And I would argue that it doesn't, because there is nothing in the Misuse of Drugs Act that prevents a person from running a facility where other people come and use a substance to inject themselves. As long as there is no supply, and as long as that person is not injected by somebody else. So within certain strictures, such as that people bring their own drugs, they're not being provided drugs, and that the staff of the safer injecting facility or drug consumption room are not injecting the people who come, then I do not see that a drug consumption room or supervised injecting facility, whatever you want to call it, would break the Misuse of Drugs Act. So I think that the Home Office's opposition to the running of a drug consumption room is more based in their opposition to the idea of it rather than to the actual laws that are in place. And the fact that Peter Crikant voluntarily set up a drug consumption site in a converted ambulance in Glasgow and was able to run it for several months without being closed down by the police shows that it is possible within the British legal framework to run such a facility. Shall I carry on with the evidence base, or do you want to talk about the legality more?
No, if you could. Go to the evidence base.
So the evidence base for drug consumption rooms is primarily built on the services that exist in Australia and Canada, even though there are at least 10 other countries that also provide drug consumption rooms. In Sydney and in Melbourne and in Vancouver and various other Canadian cities, there have been multiple studies that show the effects of drug consumption rooms in reducing deaths, reducing bloodborne virus transmission, including HIV, in encouraging people into other treatment services, and without doing what is often feared they will do, which is what's known as the honeypot effect. So people argue in opposition to drug consumption rooms that they would attract people who use drugs to a certain area, and that therefore public nuisance and crime would increase in that area. In the studies that have been done in these cities, that has been shown not to happen, and indeed the studies, particularly in the Australian context, have shown a reduction in public nuisance. For example, in the littering of used injecting paraphernalia close to the site, as well as a reduction in the use of ambulance services in those areas, and therefore reductions in costs because of the reduced propensity of overdose of drug use to lead to overdose and death. And so it's also the case that you would see substantial cost savings associated, both in the short term from reducing drug-related emergencies, but also in the long term from reducing the very expensive care that people will need if they contract HIV and viral hepatitis. Now, there is a limitation to this research. Similarly to Naloxone, it's not possible to do randomized controlled trials on drug consumption rooms. The nature of the intervention means that it's practically impossible to randomize it and test the causal effect of drug consumption rooms versus no drug consumption rooms. So the purists amongst the academic community would say that the evidence is not as strong as you might like it to be, that drug consumption rooms reduce deaths. But on the other side, we have a clear mechanism by which they would reduce deaths. We have evidence of the places that have introduced them having seen reductions in death, and so we would expect that to occur in a British context. But a third point I would like to make is that the evidence suggests that the effect of a drug consumption room is highly localized to the immediate vicinity of where you set up the service. And so people who use heroin or crack would normally tend to be looking for somewhere to use that drug very close to where they bought it or where they were at the time. And so the effect, for example, in Vancouver in reducing deaths was localized to just a few city blocks. And so drug consumption rooms are best located in hotspots of injecting drug use and overdose. Now, the question is, for me, in the London context, is the London drug market still so heavily localized and concentrated that you would find a place that would make sense to have a fixed location where you have a drug consumption room? And I think there is a mapping job to be done across London, because the drug market in London has changed substantially over the last 10 to 15 years because of the way that drug supply has changed. I'm not aware of, I'm aware that there are less places in London where people congregate to buy and use drugs than there used to be 15, 20 years ago. So if you ask me now, I wouldn't know where to put a drug consumption room in London. So I would advise that there be a mapping exercise to find out where these problems are clustered and whether it would make sense to have a fixed location or perhaps a mobile service that meets the needs of the people who are using drugs near where they are buying and using currently.
Thank you. And I think the panelists have been absolutely brilliant, because you've answered a lot of the questions all in the first question. But I just want to turn to Neve and ask you really if for drug consumption rooms in London, which stakeholders do you feel would need to be involved, and then do you have any thoughts in terms of location of the rooms in London as well?
So, I agree with Alex on the need to map the situation in London. The stakeholders that we'd need to have involved are public health, the treatment services, the police. I also agree with Alex's assessment on the legal position with regards to DCRs. We can provide Release's written opinion on this, and we can provide that again to the committee, which clearly sets out what the Home Office's position is on this and what the reality is. In terms of location, though, yes, we do need to map, but also I think some of the conversation also looks at drug consumption rooms as very fixed sites. One, there is the option of having a mobile site that could respond to different areas, but also thinking about how we develop policies and protection for those facilities where people are likely to be using opiates indoors, as well as trying to provide a facility that deals with those who are public injecting. So, for example, hostels across the city where people are inevitably going to have to be using their opiates, and where what we should be doing is providing support to those staff and to those facilities to operate effectively. We've just had a conversation about naloxone. Naloxone is a fantastic life-saving medication, but it only works if somebody else is there. And the reality is that for about a third of deaths, it's estimated that people are dying on their own. So naloxone's not going to work in that situation, and that's where drug consumption rooms come into play, where we can make sure that we are meeting the needs of people who are most at risk, either because they have to inject in public places, or because they are using and either they can't use in, say, the hostels I described because they'll get evicted, or because they don't want to use where their families are because they don't want them to see their drug use. So often what we're doing is providing a very hidden population with the facilities and the care to make sure that we're saving their lives. So like drug consumption rooms to me are one of the most important harm reduction interventions around the idea of humanity and just treating people as human beings and wanting to protect some of the most vulnerable in our society. So there is a whole piece that needs to be done practically, but the will and the desire to try to protect someone from death, and these are people who are the most marginalised, should be something that we all want to do and all are committed to. So the practicalities are one thing, but the commitment to it has to be absolutely universal. And the government's position on this is really just about the fact that they don't want to look soft on drugs, and they're happy for the lives of some of the most marginalised and the vulnerable to be dismissed.
I mean, you've mentioned and you've talked a lot about the practical and policy barriers, and that it is possible within the current legal framework we heard as well. But given the risk of private prosecution from individuals and businesses who maybe wouldn't want or won't want the rooms near where they are located, especially those that would be opposed to the DCRs, wouldn't the more realistic route to rolling out any pilot scheme or schemes in London be to obtain the green light and the confirmation and support from the Home Office and the Department of Health?
You say this, but if we look at the Irish example, so Ireland passed the legislation to permit the use of DCRs back in 2018. I'm looking at all of my colleagues here, 2017, 2018. So there's a legal framework in Ireland to allow the establishment of drug consumption room in Dublin. That all went through, the site was commissioned, but a local school actually brought an objection to the planning permission that had been given by the local planning authority. And so it's now subject to a judicial review, and there's still no drug consumption room. I think the work is not about getting the green light from the Home Office, but is working with local actors to educate them on how a drug consumption room can be beneficial to their communities. They're the people who see these very vulnerable folks injecting in public, which is a really distressing thing, both for the individual and for those who are witnessing it. They see the litter that is discarded, and it's about educating them on that piece. And in fact, if you look at, for example, the Sydney Sydney facility, prior to the opening up of the facility, there was a lot of work done to bring business along. And they really educated them. And about 68% of people supported the facility prior to its opening. Within a year, that had risen to 78% because they had seen the positive effect. So I think, for me, the piece is more about bringing community with you than necessarily waiting for legislation to come into play at the Home Office level. In terms of civil liability, around negligence, etc., that will be dealt with by having very clear policies in place that are adhered to by staff. So, for example, ensuring that people who are injecting are constantly under supervision, that there is an appointed member of staff. If they were to leave, that would be negligent. So there are ways that we deal with that through very clear policies and agreements at a local level.
I mean, just to add to that, I mean, I've visited drug consumption rooms in a number of countries, and the same story that Niamh told about Sydney is repeated around the world, in Copenhagen and Vienna and Vancouver and Montreal and other places. I've visited them, where there is initial hostility. If the leadership is shown and these things are established in a sensitive and responsible way, they invariably win public and political support across the political spectrum, because they work. They reduce street nuisance and public injecting. They reduce drug litter. They bring benefits to the community as well as the individuals, and that is why they secure public support. But there may be this initial hurdle, but it's not an impassable one. But as Niamh said, you have to bring the community and the local business with you, and there are ways of doing that. You can get people from those communities in other cities to London to speak to the various people and explain how they work and why they were hostile to them, why they changed their mind.
Thank you, Chair.
You, Andrew.
I've asked the Mayor on a number of occasions about drug consumption rooms, and he's just not really interested in pursuing them or getting involved in the debate. Do you think that's neglecting the most vulnerable of communities as well, to just not embark on a debate?
Can I say something here? I don't know that my colleagues on the panel will necessarily agree with this, but I think it's arguable in London that a drug consumption room would not be the top priority for investing both money and political capital. The greatest effect in reducing deaths is likely to be to get more people into effective drug treatment, by which I mean opioid substitution treatment or optimal dosage and duration. So it is sometimes argued that the debate around drug consumption is a distraction from things which would have a larger effect. Now, I don't necessarily agree with that, because I think we could do both. We could, if we map the presence of overdoses, for example, by simply getting the data from the London Ambulance Service about where it is that they're responding to fatal overdoses and where it is they're giving out naloxone, we could identify where the need is in London. But we should also be, and this for some people might be more of a priority, be ensuring that people have rapid access when they need it, not days later, not weeks later, but when they need it, to enter opioid substitution therapy of optimal dosage and duration, because that has proved in multiple cities to have a dramatic effect in reducing both deaths and infections.
Is it not fair to say that drug consumption rooms allow services to identify those people who are in need?
That is fair to say, but there's lots of other ways you can do that as well, and not all of them are as expensive in terms of political capital or the cost of setting a space up. So, for example, if we were doing more assertive outreach in the communities where we've got people who are dying with opioid substitution treatment, that would also be a good way of getting people into treatment. And that is something that's also been recommended by the Advisory Council on Use of Drugs here. I want to be clear, I'm not arguing against the provision of drug consumption rooms. I think they're a valuable part of the repertoire of treatment and harm reduction services that we need. But we need to base them not just on the evidence of whether they work, but also on the evidence of where they're most needed and what else is there that we could be doing in those areas that can be the most effective use of the political capital you have and the limited resources that public health agencies have.
Just to end this, I mean, I think you're, when the chair started the meeting, she asked you to name one thing that would solve the problem, and you all struggled a bit with that, because it isn't just one thing, is it? It's a basket of measures that need to take place in order to reduce the harm from drugs. Thank you.
Done, Andrew. So, Emma.
I was interested, please, what Niamh had to say in response to that, because I think that's an interested. Niamh just said that it was one of the most important things that could be done, and now we hear that it isn't one of the most important things. So I think it would be important to hear back. And I think, Niamh, I'd really like to ask you that question, though, that Andrew said. Do you think the Mayor is neglecting one of the most marginalised communities in London by ruling out drug consumption rooms?
By not rolling out?
By
not rolling out drugs.
No, by ruling out.
Sorry,
out.
I thought you said rolling rather than
Ruling, not rolling. Sorry, I'm all congested, so it's easier. Sorry.
So in terms of what Alex has just said, I agree that we need a suite of responses to the crisis of drug-related deaths across the country and in London. I would point out to the fact that there was 144 people who died on our streets last year from drug-related deaths. Those people aren't in contact with treatment. Facilities such as drug consumption rooms can allow those folks to get the support that they need. I completely agree that we need to have broader access to treatment, more funding for treatment, greater range of treatment options. I mean, this is not one size fits all. It's not one solution, as you said, Andrew. It is a range of solutions. I and my organisation would certainly say that we don't necessarily have to look at a drug consumption room in this very fixed facility way, that we could look at it in a much more kind of organic way, attached to current drug services that are in local areas. So it doesn't have to be this very expensive model that we do. We do need to have flexibility. It's a big city. It's very wide in terms of the geographical reach that we would need to meet in order to address the need. So I think there are solutions to it. I also agree with Alex that it's not necessarily the top priority, that if you ask me what I would want to see for people who are vulnerable, marginalised, and some of the most let down in society tomorrow, I would like to see them having housing. That would solve a big problem here. That has to be part of the solution. You know, why are there so many people still homeless on our streets? Treatment. Start investing in treatment properly. You know, we need to look at, and often people will say, well, this population don't deserve it. They're choosing the way that they live. Well, that's not true. These are people who are traumatized. And if we looked at them and their trauma when they were children, we would want to take them and protect them. And yet as adults, they move on to illicit drug use and suddenly they're criminals and the worst of the worst. That is a failure of society as a whole. So I think there are a range of things. So in treatment, invest in treatment options. Let's go back to prescribing diamorphine. I mean, London had a very proud history of doing that back in the 60s and 70s, of prescribing pharmaceutical heroin to people who were dependent on street heroin, and it was highly successful. So let's look at that. And DCRs are part of that picture. So I don't feel that there is a huge kind of pyramid of priorities around here, but that we need to be using all the tools in the box. And I would hope that anybody who is in charge of policy in any political position would want to take those actions, to want to look at how we save lives.
Just because I do think it's important to reach some consensus or get the panel's view. Do you think that drug consumption rooms is something that debate should be opened on as part of the London Drugs Commission?
I think absolutely it should be part of the commission. I agree with Alex that there needs to be a mapping feasibility study, but I also think we need to make sure that when the commission looks at these things, it's really important that we look at the cost benefits of each of these interventions. So, for example, we've talked about the expensive nature of drug consumption rooms in some of the cities across the world. But these facilities will mean that the 65% of people who were part of that research study that I mentioned around the bacterial infection would get their wounds treated immediately. That saves money for the secondary care services, for A&E, for hospitals. Let's start to look at, I would like the Commission to start to look at our health system as a whole and look at how we can benefit through these interventions around reducing the pressure on budgets in other parts of the landscape, the health landscape, so that we can invest properly in treatment, that we can invest properly in these interventions that we've been talking about today.
I mean, the ones I've visited in the one in Copenhagen that Prune was talking about also is an enormous, amazing facility that cost, I think, a couple of million euros. It's a remarkable place, and it'd be well worth visiting. But I've also visited ones where it was literally just two seats, two desks in a room in an existing drug service that was supervised with clean eat, and it wouldn't. The cost for that was marginal, really. This is not millions, not even hundreds of thousands. It was a marginal cost. So there is a range of different ways you can do this, whether it's the mobile ones or the big installations or the small installations. What we need is an enabling environment in terms of law and policy and politics that allows the people who have that expertise to make those decisions on which services they think is appropriate to provide. At the moment, there is this barrier from the Home Office and from certain other quarters.
Mayor of London, can we just be clear?
Preventing
The Mayor of London has ruled this out as well. So
and the Mayor of London. And yes, I think it's negligent that he's not looking at it. If you, absolutely, I do. I think anyone is. If there are services that are known to work, have been shown to work, and there are deliberate political or barriers to implementing them, that is negligence in my view.
Thank you. Can I?
Sorry, I say that as transform, by the way, not as the loop.
Prun, did you have anything you wanted to add to this discussion? Because I realise everyone else has just chipped in.
Thank you. Just briefly, I mean, like naloxone, like drug consumption rooms, where this is unmet need. These are people who, there are commissioned statutory services which, if they were fantastic or great or funded, they could be and would be accessing. So I'll always bear that in mind. I couldn't agree more with what Alex has said about, if you had to choose, where would you put your, resource and funding? And actually, it is opioid substitution treatment, opioid medication-assisted treatment like methadone, buprenorphine. It's got the strongest evidence. We need to look at those services too. And I'm talking to myself here, the services that we all provide as a sector. Easy to get in, get rid of the barriers that are there, the administration that's there, the stuff that make it difficult to just go in when you've got that window of opportunity. So I'm really passionate about good quality treatment services that are available to anybody when they need them, but it's not an either or thing. Drug consumption rooms or safer injecting facilities, whatever we want to call them, they will serve people who are not currently served by the current treatment system. They offer a compassionate approach and environment for people who currently, as we described, might be on the street trying to just get by. And that's not good enough, in my view, for anybody if it was one of our loved ones or family or friends. So I think there's a broad range of options that you might want to have in your armoury around drug-related deaths. You can't just close the door on an evidence-based intervention like drug consumption rooms without a good reason, in my view.
Thank you. Alex, did you want to come in as well?
I just wanted to add something, a broader context to this range of services that we're talking about as necessary, and those services we've been talking about today, which is that it would be a lot easier to provide these services in an effective and cost-effective way if drug possession were decriminalised. The criminalisation of people for possession of drugs for their own use is costly, ineffective, and counterproductive. It's costly because we waste a lot of money of the police intervening in these cases. It's ineffective because the reviews that I and other people have done in the field show that decriminalisation does not increase use and criminalisation does not reduce it. So we're imposing harms on people in the form of criminal records and costs on ourselves to achieve what doesn't actually happen, which is the aim of reducing drug use by criminalising people. That's not something that actually happens. And if it's also counterproductive because we're stigmatising and criminalising people in a way that keeps them away from the sorts of services we want them to be using. And I'm not just talking about drug treatment. I'm talking about, if you go to your GP and you've got an issue around drug use, are you going to tell your GP that you're using those substances if you know that's an illegal act? and it's, however much you trust your GP, you might want to tell them that you're committing a crime. So we should be, in the interest of public health and reducing opioid-related deaths, we should be decriminalising the possession for personal use of all these substances, not just cannabis, but all substances that are currently controlled under the Misuse of Drugs Act. Now, London itself does not have the power to do that, but it could, through partnership action between the Metropolitan Police and public health authorities, develop a system where we are not expecting that people who are caught with in possession of small amounts of any controlled drug be criminalised for that use, but rather they be diverted from punishment, and if they need it, given the opportunity to get into treatment. That's something that Scotland is pursuing, that various police authorities around the country, as Steve mentioned, are already pursuing, and it's something that could be done at London level that would have an effect in saving money and reducing the barriers to all these services we've been talking about, as well as reducing the barriers to treatment, not just for drug use, but for all the other health conditions that people with drug problems tend to face.
When you say it could be done at a London level, do you mean that that the Mayor could instruct the Met not to... we are straying into police and crime territory here. I'm going to get my wrist slapped. But I just want to understand exactly what you're saying there. Are you saying that it would be possible to pilot decriminalisation for small quantities of personal use within London, within the London context?
Yes, and I make no apologies for straying into police and crime territory, because the distinction is completely artificial and also counterproductive. We shouldn't be treating these things as separate. We're talking about the same people. So it's possible for the Mayor and the Commissioner of the Met to come to an agreement where it is the policy of the Met not to punish people for the possession of small quantities of any drugs. That's what's happened in other police force areas in England. It's also what's going to be happening in Scotland. And so, I mean, you'd have to bring in the Crown Prosecution Service as well, because these prosecutions are not in the public interest. As I said, they're counterproductive and expensive. It's not in the public interest to penalise and give people criminal records just for minor possession offences. That is something that could be done, I would call it de facto depenalisation. Steve would use a different term for that, but that's in the way that the police choose how to enforce the law, which the police are always choosing operationally how to enforce the law. So that is something that is possible within the current legal framework, even though I and Neve would prefer that we repeal the sections of the Misuse of Drugs Act, namely sections 5, subsection 1 and 2, that make it a criminal offence to possess these substances if there's no intent to supply, because we see that criminalisation as counterproductive, ineffective and costly. We don't have to wait for the law to change. It can be done through the current arrangements by which the police are governed.
Thank you. Well, we may have some questions. We may want to come back to you with further questions on that in writing, but that is that's really useful information. I think we have reached the end of our questions, and we've heard very clear that drug checking services have gone beyond piloting. We've heard incredible, so get on and do it. We've heard, incredible sort of unanimity over the use of Naloxone as a way of saving people's lives, and particularly, it seems, the nasal version of Naloxone. I can't imagine why it's not being more widely used. And it's been, this conversation about the drug consumption rooms has been really informative, and it's clearly complicated. There's all the complications around the community response to having a drug consumption room within their area, but also all the value, the sort of the need for more understanding of the wider value of providing people with safe places to consume drugs that otherwise would be consumed out in public in a street alleyway, or in a place that would actually put the user at much greater risk of harm. And then this final bit that strays into our police and crime committee colleagues' territory, but that's also extremely helpful, Alex. Yes, so thank you to all of you for an incredibly informative session. We just need now the committee to note the report and the subsequent discussion. And committee, will you delegate authority to me as chair in consultation with the party group lead members to agree any output from this discussion?
Agreed. May I say, Chair, just very, very quickly, I've been waited a very long time for this committee meeting, and I'm delighted that we've got here. And really, the evidence, it's difficult to summarise the evidence that's been given and the facts that have been given because there's been so much.
Yeah.
But thank you very much indeed.
It's I'm grateful to the committee that we've managed to get this onto our agenda because it's a really important issue, and I'm sure many of us know people who are living on the street who have leg ulcers and terrible consequences of that from their drug use, and sort of being able to do things that can reduce those health harms is incredibly important. Can I also ask the committee to note the work programme?
Noted.
Thank you. And just to say that the next meeting of the committee is scheduled for Thursday the 25th of November 2021 in the chamber here at City Hall, one of the last meetings that will be held here. So thank you everyone, and I just need to find the gavel so that the...
Can I just ask what the timeline of the process is in terms of you producing recommendations?
Oh, that, can I bring you in?
TBC is probably the best answer.
To be confirmed.
we'll get back to it.
Good answer.
But usually it's
quicker than the mayor has done to set up the London Drugs Commission.
Yeah, it's usually a process that takes a couple of months of back and forth, but yeah. So I will now bring the meeting to an end, and thank you very much. Thank you, all of you, and Alex.